All right, guys, this is going to be chapter 15, the BLS resuscitation chapter. It's basically a review of AHA CPR guidelines, and then putting a little bit of ALS stuff in there, which is something you'll be adding on. Here's your fundamental knowledge and EMS education standards. Basically, we're going to be looking at the assessment findings for a patient in shock, in respiratory failure or arrest, cardiac failure or arrest, and then post-resuscitation management. All right, the biggest thing about cardiac arrest, respiratory arrest is everybody working together as a team. This is something that's been worked on since the 1960s, where cardiopulmonary resuscitation emergency care had been reviewed and revised about every 5 years. And that's why we go back, a lot of times we go back to HA classes. So just a lot of times you'll have a team leader, let that team leader do their job. It makes for a positive outcome and more fluent and flowing resuscitative effort. And then, that person doesn't have to be the team leader all the time. So, even if you have an AEMT and a paramedic combo on a truck, I've let AEMTs be the crew leaders before. They can recognize rhythms. They may not be able to push all the drugs, but, being able to say, hey, paramedic, I need you to do this, quickly, we've had this rhythm change. So just being able to work together. All right. In cardiac arrest, we'll use the CABD sequence, the compressions, airways, or circulation, airway breathing, disability, and exposure sequence. Okay. So we want to go straight for the chest compressions, get that circulatory system going again, and filling those vessels with blood with the oxygen that is left, in the body. So brain cells die every second that they're deprived of oxygen. So as you can see here, past the 10-minute mark is usually irreversible brain damage. So we need to get those chest compressions started early. Even if you don't have access to an airway device, at least get the chest compressions going. So here's CPR, is circulation and artificial ventilation of a patient who's not breathing and has no pulse. So we're going to have that 30-2 ratio, 30 compressions for every 2 breaths, making sure that the chest recoils and comes back down, making sure that the ventilations are making the chest rise and fall. Right, we need to quickly identify somebody that needs ALS. A lot of times BLS is being administered prior to us getting there. And then, use the advanced AEMT now. I want to have that capability of providing ALS measurements. So that could be cardiac monitor, it could be IV, IO, fluids and medications being established. Here's your chain of survival from the AHA. So, best thing is that we recognize that, or somebody recognizes that somebody's in cardiac arrest or respiratory arrest. So they end up calling and activating the public response, emergency response system. And we go from there to, the high quality CPR, hopefully getting to people that are there pretty quick. And then units start arriving and we get that post arrest care. All right, if any one of the links in the chains apps are not maintained, the patient more likely to die. Hopefully we get that IV IO access established pretty quick. Hopefully there's a defibrillator there, in less than 10 minutes. Because after that 10-minute mark, we may have that irreversible brain damage being occurred. IVIO is one of those things that's going to be up to your local agencies and policies and procedures. A lot of agencies are going straight to IO access, just due to the success rate of them, and be able to push those drugs pretty quickly. And knowing that that IO is in place. Next, we're going to look at their reversible causes of cardiac arrest, and that's to include your H's and T's. So don't forget about that: the hypovolemia, the hypoxia, the acidosis, the hyperkalemia and calcemia, hypothermia, tension pneumothorax, tamponade, toxins, your toxicology reasons, and then your coronary and pulmonary thrombosis. Here's our rhythm. For starting CPR, check the rhythm, and get your AD in place. Treat your treat your reversible causes, and then possibly provide transport. Or if we don't have any success, we might have to terminate it for medical control. All right, I always begin by celebrating the same. Is it safe? Is it safe for you to be there? Many cardiac arrest situations are high stress. Um, could be an acute setting, and family members and friends were not expecting it. How many patients do we have? Do we have an MCI of some sort? Do we have an outbreak of something that's going on unknown at this time? So we need to be careful with that. What's your general impression? Are there any bystanders who may have additional info? What's the mechanism or nature of illness? Do you think there's trauma? So, of course, you want to start with, hey, you're okay. If you do suspect trauma, make sure you make sure you stabilize that C-spine, and then go from there. The principle is pretty much the same for infants. Covering the underlying cause. Just know that there is some difference in providing CPR to the infants. If you've got to pay a person doing CPR on a newborn neonate, don't forget about it 15 to 2, and unless all the other ones are 30 to 2. Cardiac arrest in adults usually occurs before respiratory arrest. So respiratory arrest usually occurs before cardiac arrest in infants and children. So I always think airways in your pediatric population. AEDs, if they're there, they're good. Put them on. Of course, they're only going to recognize the pulseless fib, the VTAC. It may or may not recognize it. It depends on the mechanism of the monitor. Okay. So I would not think that AED would shock, VTAC without knowing it had a pulse. And as we all know, VTAC can have or will not have a pulse. All right. Safety is using a pediatric sized pads and those attenuating system. Apply after the first 5 cycles of the CPR. And for infant, a manual defibrillator is preferred. So never cut the adult size pads to adjust to the size. So if you have to put one on the front of the patient, one on the back, that's okay. Just make sure you have the dual reducer in place. Or if you have the correct size pads, please use those. All right, pacemakers, make sure you put them an inch away from the device. Make sure you don't use the AED in water. It is electricity. So water does carry electricity, and might be some other patients there. Razors to take off the hair that may be on the chest so that you can place the pads there. Transdermal medication packs, just make sure you wipe those off when you take those off. Okay. Patient needs to be lying supine on a firm, flat surface. So ensure there's enough space for 2 rescuers to work and perform CPR and use the AED. I've been in some tight spaces. Some bathrooms are really tight. And sometimes you just have to pull the patient out into the hallway or pull them down to somewhere that, everybody can work on and work together. If you need to, put them on a backboard, carry them out the way you can get to them more efficiently. All right, check for breathing and pulse. Check your carotid pulses first on your adults. Check your brachial pulses on your pediatric population. Hopefully, the lead person is evaluating chest compressions and all the different procedures that are going on. So, making sure that chest recoils, making sure that it's correct placement in between the nipple lines. Remember that you are being the pump of the heart at this point. All right, nice and smooth, rhythmic, uninterrupted. Try to compress for about every 2 minutes. And then this is letting the chest completely recoil, but also making sure that you keep yourself in line with the chest. Okay. I see a lot of people that lean backwards a little bit, have their hips lowered down. and they're trying to do compressions at an angle that's really not as effective. All right, head tilt chin lift if you need that in the adults, and jaw thrust maneuver if you suspect anything with trauma patients. All right, place the patient in recovery position if they are breathing adequately, and no signs of spine, hip, or pelvis injuries. So breathing in is lack of oxygen combined with too much carbon dioxide in the blood. So ventilation should be delivered over 1 second, and it prevents the air from being forced into the stomach, resulting in gastric distension. This has been a lot of studies being conducted on ventilations too. So we want just enough squeeze of that bag to actually see the chest rise and then being able to let it fall. If we squeeze too much air, of course, someone's going to forcibly probably be pushed into the stomach. We could also cause too much expansion of the thoracic cavity too, and cause problems there too. All right, HC method, they're using a barrier device as much as possible, and hyperventilation can cause endothoracic pressure, and it may not relieve itself. Here's a stoma. It's an opening that connects the trachea directly to the skin, so use a pediatric infant mask through ventilation through the stoma. All right, if you do have gastric distension, you're gonna find out what they ate for last time they ate. So you should be able to spot this. The stomach's expanded. It's not being relieved because we're constantly pushing too much. So slow down, give good general breaths. Let things go as they need to, and if you need the suction, make sure you get make sure it's available. All right, there's one rescue CPR with a ratio of 32. To rescue CPR, get your airway adjunct set up, possibly insert the OPA. So the pit crew methodology is out there. So it's just kind of making sure that everything's being taken care of and being done in a systematic way, even down to a timekeeper. Most monitors do that for you now too if you punch it in. But a lot of law enforcement officers will keep time for you. They will do that more than anything else a lot of the time. So make sure we respect the team member. If the team member is a great leader, they'll get advice from the team itself, so that everybody is working together. Okay. So using the pacing monitor, we probe, we're looking at our ass to confirm the problem. We are alert, so we communicate the problem with the team leader. If we have a challenge, if the issue is not corrected, challenge the team's presence, course of action. In an emergency, if the problem is clear and critical, immediately communicate the emergency to the entire team. So you may have a ventilator, an active compressor, somebody's on deck to compress, and then your timekeeper, maybe somebody's grabbing medications for you, somebody that's keeping the equipment going for you. So the co-team really needs to be knowledgeable and expert and be able to jump in, perform a skill if needed, or be able to critique somebody on their doing other skills. But we need to be able to critique in a way that is positive. All right. If an effective cardiac rhythm is restored in the field, provide transport. Go ahead and get glucose levels, temperature levels, and always make sure that you're leaving your AED pads in place. The unit cardiac arrest is probably going to ensue again, more than likely. Okay, making sure we got optimum ventilation, oxygenation, treat hypertension, try to get it to around 90 systolic. Look over your H's and T's again, possibly a saline bolus or some type of vasopressin infusion Please do not forget to get twirlies. If you do, obtain a pulse back. That's very important. These patients need to go to a PCI center, and then always treat your temperature for management. Okay. All right. This is just some different devices out there. The impedance threshold device, your Lucas device, auto pulse device to help you with chest compressions. Um, I always think respiratory rest, focus on the airway in your pediatric population. So, never shake a child to determine responsiveness, and then possibly do CPR prior to calling 911. All right, visualize chest rise and signs of breathing, palpate full pulse and large central artery, and then in inference, palpate your Baker artery. All right, there's your two rescuer with the 15 to 2, and 30 to 2 if you're working alone. The foreign body obstructions, of course, we're going to up their way using the setting techniques used for an adult. But if they are breathing, place them in the recovery position. Don't forget about your head tilt chin lift on your medical patients, and then your possible jaw thrust on your trauma patients. All right, rescue breathing every 2 to 3 seconds. Also, with infants and children, please make sure that you have the correct size BBM, so that you're not overexpanding the lungs in this situation too. Once again, making sure that the chest is rising and falling with each ventilations, and doing it nice and slow. All right. Depending on your local protocols and policies, as far as doing CPR on the scene, or if you need a paramedic backup to help you make those critical decisions as far as stopping CPR or discontinuing CPR, please make sure that you're familiar with those. You may need to rendezvous and meet them en route to the hospital, or you just may need a transport. All right, so rigor mortis, dependent lividity, purification, and mortal injury itself are reasons to not start CPR. Okay, rigor mortis takes hours to set in. Lividity is the lining of the back where blood is, gravitationally going down. Purification is actually decomposing of the skin that has started. So a lot of these patients have been there for a while, and there's really nothing more that can be done. Mortal injuries such as a decapitation, dismemberment, or burn beyond recognition are also reasons to not start CPR. Okay, but if you're in doubt, always cover yourself and go ahead and start. DNR orders on most forms are out there now. And, you're gonna have a lot of discussion about those, especially in between family members. But a lot of times, if you just sit down, coach these, the family and the friends on what's going on, this is, the patient's wishes. Sometimes, a lot of them will understand. All right, here's a mnemonic for stopping CPR. Body or airway obstruction, such as these. We're going to do something that can't be removed from the mouth. You may have to use the glove finger, possibly if you see it, go get it, and always have suction available. There is your universal sign. As long as they're breathing, let them breathe, and cough, and possibly they could, cough it up themselves. All right. Always let the patient know what's going on with the Highland maneuver. So, and then chest thrust on your pregnant or obese patients. All right, and once they become non-responsive, go ahead and start CPR. Right, pretty much same thing in children. So abdominal thrust and repeat. If they become unresponsive, start chest compressions. Infants, do your back um, slaps and then your chest thrust if needed. All right, opioids are out there. Narcan's, please remember that Narcan is used for respiratory depression and respiratory reversal. Um, so a lot of it is out. Narcan is out there, pretty much common amongst a lot of people that maybe have been administered prior to you arriving there. Just make sure that how much was administered and what route has been administered. So pregnancy, high quality CPR relief, pressure off the aortic vena cava, and then sometimes you have to manually displace the uterus. Okay. So when we decide not to do anything for a patient, some family members are not going to understand that. Um, but we need to be professional enough to explain to them why we're not making that decision not to provide resuscitative efforts to their family member or their friend. Okay. Um, being able to sit down and talk with people and being able to, discuss why we're not doing anything. If that doesn't seem to help, possibly having some grieving services available um, would be your next best step. All right. So um, if we're in the middle of a code, designate somebody to walk over to the family, let them know exactly what's going on. Tell them that we're not getting a response back, from his or her part, and we've pretty much done everything that they can do inside the hospital here. Okay, but the best thing is to keep these family members um, aware of the situation. A lot of times you can take the next of kin into another room, advise them what's going on. And a lot of times they're be okay and side with you on the next step of stopping. All right, CPR is about every 2 years, and that's the end of this chat.